use, and then where we can use them and how we can use them in day-to-day practice. So to begin with, let me just quickly start saying about what is ventilation. What is the purpose of ventilation? What do we do when we ventilate a child? In simple words, all we do is we give oxygen, we take out carbon dioxide, and thereby helping the baby's lungs to do the job. What dictates oxygenation is the pressure and oxygen. We all know this is the PIP and PEEP and FiO2. What dictates the CO2 movement is essentially about what happens to the respiratory rates, and then what is the delta P, that is your PIP minus P. So this sounds very simple, but practically when we are doing it, there are lots of practical issues, such as there may be leaks at the ET tube level, there may be secretions in the tubings or in the ET tube, and the baby's lung pathology keeps evolving. Like on day zero, day one, baby may have RDS, and subsequently baby may have picked up a pneumonia or a VAP, or maybe baby may have a pneumothorax, and thereby the lung mechanics also keep changing with time, and which demand us to change our the way we handle the ventilation of the baby. So how do we monitor a baby on a ventilator? Okay, this very common thing that we routinely do bedside is clinical monitoring, where we have a lot of scoring systems. So I don't generally like using subjective things like baby was slightly worse, baby is slightly better, baby is slightly worse. It is better to use an objective scoring system such as Downey Vidyasagar score or a Sullivan Anderson score, or one of those scoring systems. We can say baby was 1 by 10 in the morning, baby is now 4 by 10 now, so thereby we know that baby is worsened, stuff like that. So beyond clinical monitoring, we can have a lot of you can use a lot of gadgets and equipment such as multipara monitor, where you can look at the SpO2 baby saturations, how they are doing. They're more than 90 to 95, or they are less than 90. How is the heart rate? Heart rate generally is not related to ventilation as such, except in terms of hypercarbia. Whenever there's hypercarbia, generally tends to be more and more tachycardia that we notice in children. Respiratory rate, again, where the baby is comfortable at 30 to 40 breaths per minute, may go up to 80 or 90 when the baby is not so comfortable. So all these things give us a clue that the baby is doing well or not doing well in terms of ventilation when we monitor baby on ventilator. ABG, we all know, we do it on a regular basis to check out the pH, PaO2, PCO2, and then of course any metabolic acidosis in terms of bicarb and base-excess. But excluding all this, like my current topic today is on pulmonary graphics, where we look at the mechanical aspects of breathing. So this is looking at every breath of a baby. In a sense, every breath the baby moves, then we keep looking at how it's changing in terms of baby's own pathology change, as well as a response to whatever we have done for the baby. So this brings us to the concept of ventilation. What is love? Okay, we need to involve a lot of love when we ventilate a baby, is what my teacher used to say. Love is nothing but the loss of ventilator efficiency. That is, we should know our ventilator, we should know our disease pathology, what we are ventilating for. We should always have a specific strategy for each of those pathologies. We should keep changing our strategy whenever we notice that the pathophysiology of the disease change, such as, like I said, where an RDS moved to pneumothorax and RDS moved to pneumonia, we need to change our strategy, what we are applying to the baby. Always be in a search for an exit strategy during ventilation. We should always try and come out of ventilator as early as possible. Otherwise, we end up paying a heavy price for continued ventilation where it's not needed. So when we are using graphics, what are the primary goals, or what are the primary things that we look at for its utilization is, one, it gives us an objective evaluation to a treatment. Say, when I talk to you about certain loops, we know that the baby's lung compliance has been terribly low, and then with a particular treatment such as surfactant administration, the compliance improved. So such objective evaluation is right in front of our eyes. It can also help us optimize ventilator settings. There are certain ventilator parameters that we set when we begin, but then when looking at how the baby is behaving, we can always change those ventilator parameters based on these graphics. I'll be talking about that too as a part of the rest of the slides. It can help us understand what changed in the pathophysiology. Like I said, in RDS lung, we look in a particular way, and then if it moves towards pneumothorax, it will appear in a completely different way. It will help us facilitate the weaning process when we are weaning the process, and of course, it helps us quickly make a decision about what changed in terms of baby's sudden crash, such as tube leakage, or is it secretion? Is it a dope scenario where there is a pneumothorax or the ventilator stop working suddenly? All these parameters we get to know. So what do we need to have our graphics in place? We need to have a fantastic flow sensor. Okay, this is the first point where we need to make sure that it's working well. So many a times, if the flow sensor is not working, then whatever we are using as a ventilator mode may not be the exact ventilator mode that's being done to the baby. Say for example, if your ventilator shows an alarm saying calibrate flow sensor and it is not calibrated, even if you are planning to give SIMA mode of ventilation or assist control or volume guarantee, the ventilator ends up giving IMV, that is mandatory ventilation, where none of the other things work at all. Like we are trying to synchronize the ventilation along with the baby's breathing may not really work. We also need to have a screen so that we can see what's happening with this graphics. So the primary parameters that are measured are, it is pressure, time, that is measured at the machine end of the ventilator. Flow and volumes are usually measured very close to the baby because this is where the flow sensor comes into picture. So because these are very small parameters, very sensitive parameters, they are measured as close to the patient as possible. How do we use this graphics? We use this graphics first in, like I said, the trends. When I see the baby on a ventilator at the beginning of ventilation, to subsequently to what the baby's response is to my treatment as well as to time. And each scalar or loop can be used to identify a particular pathology and address the particular pathology. So what are scalars, what are loops? These all sound very big words, but then they are just simple parameter things. Scalar is nothing but any parameter jotted against time. So the usual parameters jotted against time are your pressure, your flows, and your volumes. So the pressures is nothing but the machine keeps measuring the pip, the peep, how long we use the pressure, the pip, and how long we let the baby breathe out into the peep. Flow again, like I said, inspiratory flow and expiratory flow. And volumes is how much volume is delivered into the baby and how much got out of the baby. Loops are where you jot each parameter against each other, such as your pressure volume loop or your flow volume loop. In the sense, when you measure against the pressure, what's happening to the volume of the baby with each breath, and again similarly with each flow, how much volume is going into the baby and how much volume is getting out of the baby. These are the loops that we normally study when we address this pulmonary graphics in neonates. So I'll quickly spend a little time on scalars. So like I said, each of these parameters is measured against time. In the sense, with in a real-time scenario, how the pressure is moving, how the flow is moving, and how the tidal volumes are jotted down on a baby. So this is how the normal ventilator screen looks like. Irrespective of the kind of ventilator we use, the more or less these parameters are measurable in almost all ventilators. The chota screen that is there on the ventilator can also show these parameters. If you have an attached bigger screen or an attached screen for any of the ventilators, you can see all of these parameters. So the upper thing is the pressure, the middle thing is the flow, and then the lower thing is the tidal volume that you're seeing here. So the first scalar that I'm going to talk about is a pressure time scalar. Okay, so what do we do when we look at a pressure time scalar? Pressure time scalar, like I said, is also called a map loop. It talks about the complete mean airway pressure that we are giving to the baby. So this you can see the y-axis is the pressure, and then the x-axis, like I said, is the time frame that with which the breathing is happening. So this particular blue and red trace is the pressure scalar of this particular loop. Now, when you see this baby, this baseline pressure that is being delivered to the baby at all times is the PEEP that we are setting up. That is end expiratory pressure we want at all times for the baby. And when you're seeing this upbeat, this is the pressure that you're giving in the peak. This particular point is the peak inspiratory pressure that you're giving. From this point till this particular point is the inspiratory time that we are delivering to the baby. And from this point till this point is the expiratory time that we are allowing the baby to breathe out. Okay. So this particular scalar, the pressure time scalar, the area under this curve is nothing called map, which is also a direct reflection on how much pressure we are using to oxygenate the baby. Now, what is the first thing that this particular scalar will tell me? This particular tell me whether the baby is initiated the breath or the machine initiated the breath. Or in other words, is it the mandatory or the controlled breath, or is it an assisted breath to the baby's breathing? So every machine will have its own color code. This particular machine, this particular red breath is probably a machine derived breath where the baby is not at all breathing in this particular scenario. If the baby breathes, then it will have a different color. Like in this particular machine, it is going to be yellow. Like I said, the mode of ventilation also can be assessed by looking at the pressure scaler. Once you look at the pressure scaler, you know whether it is an SIMV, that is synchronized intermediate mandatory ventilation, or assist control, or a volume guarantee form of ventilation, which I will also show you how the pressure scaler will look like. This particular scaler, like I said, will also tell us how much P we are using, how much PIP we are using, and also how much is the flow rate. Like for example, in this particular, the rate of rise of the inspiratory breath in this particular loop will tell us how much flow we are giving. If we give a very high flow, it will be like a square. If we give a very slow flow, it will be like a sinusoidal wave. Okay, like I said, this also tells us what are the different types of modes of ventilation that we're using. This topmost ventilatory thing that you are seeing is probably an assist control or an IMV mode of ventilation, where every pressure is pulled up to a particular monomorphic kind of waves. The second wave is SIMV, where some breaths are supported and all the breaths below the rate that you have set are not supported. Thereby, these are the patient's spontaneous breaths, and these are machine assisted breaths. Like I told you, this is a baby breath that is assisted because the color coding is different. This particular pressure, if you see, it is varying. Okay, it's increasing, decreasing to the needs of the baby. This is nothing but volume guarantee mode of ventilation that is used in minutes. So from a pressure scaler, we'll get to know what are the pressures that are set, what is the kind of ventilation that we are using, and again, what is the flow rate that we have set in the ventilator. The second important scalar, the most important scalar, is the flow time scalar. Okay, so this is the inspiratory flow and this is the expiratory flow that we normally see with each breath. In the inspiratory limb, we would like to understand whether the breath is being triggered by the machine or with the baby. And also, this particular thing will also help us understand what is the inspiratory time and how to optimize it. I told you it will help us, the graphics will help us set the ventilator settings. This is one of the important application of it. In the expiratory limb, it will also tell us about the adequacy of the expiratory time that we have, resistance to the expiration of the breath of the baby, and also helps us to understand whether there is any leak or air trapping that we noticed in the flow scaler. Practically, what do we notice? Like I said, in the inspiratory limb, we try to help and understand what is the inspiratory time. So this is the inspiratory limb and this is the expiratory limb. Here in this particular scalar, if you see, the baby's inspiration is long over. There is a long phase of no flow in the breath and there is an expiratory phase. If you look at the pressure scalar with the same breath, the pressure is lifted up. This is the PIP, the peak of inspiratory pressure has been set for a very long time without any flow. So in this particular form of ventilation, the PIP that has the inspiratory time that has been set is extremely high and probably the baby does not need that much. We should try and target the inspiratory time to be just enough without any area of no flow. So whenever we begin a respiration, we generally set 0.35 seconds or zero point 0.4 seconds depending on the baby's size and weight and all those stuff. But the moment you see something like this, probably we need to titrate the inspiratory time to allow only adequate time for the peak pressures to hit the lung. If we end up giving higher pressures for a longer time, that is nothing but barotrauma. Any disturbance to this particular inspiratory flow, which is normally noticed with lot of secretions that are present either in the tubings of the ventilation or in the tracheal tube. So whenever you see a lot of disturbances, then you can address the secretions to see whether it smoothens out or not. In the expiratory flows, the normally what we see here, peak expiratory flow. What is the peak expiratory flow in the particular baby? How is the expiratory limb of the baby doing? Does it return back to the baseline? Or what is the time that we allowed for the expiration to happen in relation to the inspiratory time? All right. So, like I said, this expiratory limb, this peak point at which the expiration happens is the peak expiratory flow. We all are aware that whenever there is a resistance to the flow, this tends to get more and more lesser. We can also see its response to what we do, such as in a baby, say in a baby with a BPD spell, baby is having a lot of bronchi, you have used nebulization, then you see a drastic change in the amount of expiratory flow in this particular expiratory limb. The second thing is whether it returns back to, to the normal baseline or not. I will talk about it more when I talk about air leaks and as well as pneumothorax. Expiratory time, when we use too little expiratory time, when it doesn't return back to normal, then we know that probably we need to change the expiratory times or allow to bring down the respiratory rate to allow more expiratory time so that the baby breathes it out and thereby there is no chance of pneumothorax. In this particular expiratory flow limb, we are seeing that there is a lot of this, like a hockey stick or a scooping of the expiratory curve, which we normally see with increased resistance to the expiratory flow of a baby. Probably this baby has a lot of bronchi, which probably responds to either nebulization or a thorough suctioning, so that both probably can address the scenario. Like I said, whether this particular expiratory limb comes back to the baseline or not. Okay, if it is not, if it is coming back to the baseline but going over and above the baseline, probably that would mean that there is a lot of leak that is noted at the ET tube level. This can be calculated also on the machine. We can see the leak percentage. The leak percentage. A point about leak percentage is you do not want it to be zero. If it is zero, that means that the tube is very snugly fitting into the trachea, which would mean that probably at the time of extubation we will be in trouble. We want it somewhere between 0 to 10%. Anything till 20% is still acceptable. Beyond 20% would mean that if the baby is oxygenating well, we leave it alone. If the baby is not oxygenating well, probably we need to move on to a higher size tube so that the baby doesn't have so much leak. In this second particular graphic, in the flow graphic, you are saying that the flow curve, like the dotted line, should have reached the baseline, but unfortunately this is not reaching the baseline, whereas inspiration is starting before that. This gap volume is nothing but air trapping or autopy. That means this particular volume is staying back in the lung. This would mean that the lung is getting more and more air being trapped, or there is already a pneumothorax or another form of air leak that is happening in the lung, which we need to pay close attention to. So much for the flow time scaler. I said we look at both inspiratory and expiratory. Inspiratory limb will tell us about the I time and also secretions. Expiratory limb will tell us about a lot of things such as any leak or any air trapping or any resistance to the passive flow of the air into the air or out into the ventilator. The third scalar, the third particular loop that you normally see in the particular graph that you see is the volume time scalar. This is nothing but from the beginning of the inspiration, there is an upstroke, and there is a beginning of expiration, and there is a return to normal. So technically, this particular this peak of this particular cone will give us the tidal volume that is happening with each breath. That is the amount of air that is given into the lung with each breath. Say this expiratory limb is not coming back to the baseline. That means some amount of air is leaking out when it is coming out. That is nothing but the leak at the endotracheal tube. So what do we normally see in this volume scalar? So we get to notice what are the tidal volumes that are delivered to the baby's lung. It will also help us compare the mandatory breath versus the spontaneous breath. We discussed in the SIMV the pressures are different with the assisted or a mandatory breath versus the baby's own breath. So when you for the same breaths, when you look at the baby's breathing, then you know how much volume of tidal volume the baby is able to generate when the baby is breathing spontaneously. They say when the baby is at least able to generate 50% of the normal mandatory breath. Say for example, a tidal volume of, you notice 8 ml for a 2 kg baby in a mandatory breath, and when the baby is breathing by baby itself in a spontaneous breath, it is around 6 ml, then you think the baby is actually getting ready for extubation. We also get to see any leak in the ET tube. Like I said, if the expiratory limb is not returning to the baseline, then probably that is the that whatever gap is there, that gap is the leak that we noticed. So there are this is the what I'm talking about. You have a mandatory breath and assisted breath, and you have a spontaneous breath. So this particular spontaneous breath tidal volume will give us a clue how much the baby is able to generate. And they say if it is at least 50%, that is quite useful in terms of extubatory readiness of the baby. So scalars, we said there are three scalars. The one is the pressure time scalar. The second one is a flow time scalar, and third one is a volume time scalar. Now, when we measure each of these parameters against each other, we get a lot more data. Okay, so these are comparing one parameter or the other. When we talk about flow volume loop or a pressure volume loop, we look at various types of parameters. I'll be talking about them shortly. So when you chart flow of a baby against the volume that is delivered to the baby, then we get to see this flow volume loop. So this is a normal breath of a baby. On the y-axis, I have the flow jotted. On the x-axis, I have the volume jotted. So by convention, the inspiration is generally above positive and the expiration is below. It can be other way around. It can be set by us also in the set ventilators. So if this particular, in this particular loop, what all we can see is one is the functional residual capacity, because that is the point from which the normal breathing starts and ends. It also tells us the peak inspiratory flow rate. It gives us the tidal volume on the x-axis. It also gives us the peak expiratory flow rate.
वैक्सीन के लिए तो नहीं लिखेंगे.
And then it will also help us understand whether it is returning back to baseline or not. So this is a beautiful loop because it gives us a lot of idea about what is happening with ventilation. So the pathologies which are normally detected from this particular loop are, if there is any leak and the extent of it, I'll show you how it looks like. Whether there is any air trapping, subsequently pneumothorax, or already existing pneumothorax. Whether how the expression of the baby is going on, and if there are any secretions that are there either in the tubings or the ET tube. So this is one such loop. Say the white part of it is the normal breath, and the red one is an abnormal breath for our understanding. Here the inspiration has started. It is quite smooth. The expression has started, but it ended much earlier on the baseline. So this particular ending on the x-axis baseline is called air leak or the leak at the ET tube. How much ever is the leak in the that can be calculated as a percentage. This is an ml against the total, and it will also give you as a percentage. So when you see a loop is when it is ending much earlier on the x-axis, it is air leak. Now, on a different patient, the inspiration has begun, the inspiration has ended, the expiration has begun, the expiration. Normally, we expect it to come back to where it began, but if it is marching towards the y-axis and there is a gap like this between the starting point and the ending point, this is nothing but air trapping, or this is the amount of ml that is lost inside the lung, which would also mean that is the amount of pneumothorax that's happening. Like the moment you have a baby crash on a ventilator, when you do look at this graphic, if the graph is showing this way, it probably should worry you for a pneumothorax, and thereby we should investigate accordingly. Now, like I said, the third pathology that we can pick up is a increased resistance to expiration. So, like I said, the white one is the normal breath, the red one is the abnormal breath. When we clearly see that for this baby, the red breath is lower, that is the peak expiratory flow is lower, and it is scooped out completely. So this scooped out pattern and decreased peak expiratory flow will suggest that this baby is having a lot of resistance to expiration. So this could mean either there is a lot of secretions in the lung. This could also, in the acute phase, in the long run, it could mean a BPD spell. It would also mean any bronchiolitis in a baby presenting in the third or fourth week into our unit. So all these things should be prompted from this particular simple loop that we see on the ventilation. This is in this, the green color is the normal and the white one is the abnormal, where we see there's a lot of sawtooth pattern, that's what it's called, or is a lot of ruggedness in the expiratory limb. Okay, this particularly favors a lot of secretions that are present in the ET tube. The second form of loop that I'm going to talk about is the pressure volume loop. Okay, this is how the normal pressure volume loop should look like. On the y-axis, we have the volume. On the x-axis, we have the pressures. So with each pressure, we know the pressure is increasing into the lung, and thereby the volume that is going into the lung is also increasing. So this is inspiration and this is expiration, and this is touching the baseline. So the topmost point is the highest point for both pressure and volume. So that would mean that this is the pip and this is the tidal volume. So when we look at this particular pressure volume loop, this is another important loop that gives us a lot of understanding what are the parameters, how to set and what to set, and how to go about baby's condition and setting up, changing the ventilator parameters. The pathologies that can be studied from this simple loop are: what is the optimal PEEP setting that we need to put for this particular baby? Is there any, are we using excessive pressures? Thereby the lung is going into over distension. How is the compliance of the lung? Compliance is nothing but how much the lung is opening up to the unit pressure we are giving to the baby. So is the lung compliance good or bad? It can also help us understand the nature of breath that is there in the baby, and sometimes when we are not giving enough flow rate in the ventilator, it will also tell us that the baby is actually struggling because of low flows. So this, I would want to just briefly touch upon a concept called inflection point. Okay, we all have studied in our pathology classes. We understand a balloon when we begin to blow into it. So it opens up slightly, and after that, it becomes very easy for us to keep it open. And then, if we don't allow it to collapse completely, the blowing into the balloon and letting the air out of the balloon is easier. Similar thing we talk about ventilation also. Why do we use PEEP? We use PEEP because if we keep the alveoli open, partially open, it becomes easier for us to inflate and deflate it in the subsequent breaths. This inflection point is that point after which the blowing into the balloon becomes easier. So in other words, that point is the point where PEEP is optimal for the baby. So the moment you see this is the amount of pressure at the inflection point in the lung, then we know that that is the PEEP we need to use for the lung. So traditionally we use around 5 or 6 PEEP, but when we look at the particular loop in the lung, it can also help us understand, can it be lower down or should we use higher? Should we use higher PEEPs for a particular lung? The second part I said is over distension. In other words, are we using too much of pressure in when we are ventilating the baby? Okay. So when we look, I want to draw your attention to this particular loop. This is the inspiration. This is the expiration. We realize that till a point the lung is opened up quite well, and after that the lung is not opening up well. This particular thing is called beaking of the PV loop. Beaking of PV loops tells us that we are probably using too much pressure than what the baby can tolerate or need. So in other words, the PIP that we are setting is extremely high for the baby. So probably we need to come down on the PIP, or if we can't do it, probably change the mode of ventilation to high frequency or so. So this we see when we are trying to desperately increase the PIP and PEEP and FiO2 to try and get the baby to oxygenate in settings like PPHN or pulmonary hypoplasia. So the moment you see beaking, probably we need to stop and take a step back in terms of PIP. The third thing I said is this gives you a very good understanding of compliance of the lung. Okay. So you can choose any, say, let's say the green one is the normal lung. Okay. And then the yellow and the pink one are the ones that happen after that. So if you have a baby who had a green kind of loop in the beginning and then it became pink after certain changes in ventilation, that will tell you that this probably or certain changes in the baby's lung condition, the compliance of the lung is coming down. So the more the loop is going towards the x-axis, the worse the compliance of the baby is. The more it's going towards the y-axis, the better the compliance of the baby. Thereby, you know that the baby's lung is improving. This scenario we normally see when we give surfactant. Say, for example, this is the first breath of the baby, RDS baby, and then you give surfactant. You will notice that within no time, the baby's lung is compliance is improving and it is moving more towards the y-axis. The third thing I told you is the amount of flow that we are using. Say there are certain ventilators such as Drager ventilator and Mackay ventilator where we can change the flow rate that we are giving to the baby. Necessarily, you don't have to worry about it, but the other two ventilators we have to. Whenever the flow, if it is not sufficient, then we see that the inspiratory limb of this particular PV loop tends to also cave in or curve in. Or sometimes if the baby is breathing in between baby's own inspirated breath, that means that the flow is so low that the baby had to suck in more air for breathing. So this kind of caving in is seen when we do not give adequate flow. It's called air hunger that we notice in babies on ventilation. That this is a very grave situation where we quickly need to change the parameters so that the baby's inspiration gets better. I told you we can also identify the type of ventilation that we are giving. The rightmost curve in a PV loop. If you see the PV loop, like the rightmost one, that is the spontaneous breath. The middle one is like a fish tail, that is a assisted breath. And if it looks like a nice spindle, that probably is a completely mandated breath given by the ventilator. This also will tell you how much the baby is breathing, how much the baby is needing the ventilator to do the breathing work. Now, so I have told you a lot about the kind of scalars and the kind of loops that we use. Okay, if we have to sum up in some of the pathologies that we routinely see day to day bedside, the first thing is leaking of the AT tube or leak at the trachea level. The second one is any air trapping or pneumothorax, and third one is secretions. These are three common things where we employ all these pulmonary graphics on a day to day basis. ET leak can be noticed, like I said, first of all in the flow scalar. In the flow scalar, when you see that the expiratory limb is going above the above, and the inspiration is starting from a point above, then it is a indication that there is a lot of leak that is happening in the baby's lung. The second thing is when we see the PV loop, if the expiratory limb is not going back to the starting point and it is dropping suddenly, like a sudden drop, then that also will tell you that there is probably a lot of leak that is happening at the trachea level. And the best loop to look at leak is our flow volume loop. When you see the flow that is going, inspirated flow is good, the expirated flow is dropping suddenly on the x-axis without touching the baseline like it should, then whatever is left out is the leak that has happened at the trachea. Air trapping or pneumothorax is the second important thing that we see. This is a very important thing when we are using very high parameters for a small baby or very high parameters for a mass PPHN scenario. So whenever you see in the flow scalar that the expiratory limb, like it normally should touch the baseline, it is not touching the baseline, and the inspiration is taking over from there, then this is called air trapping or autopy. If it is beginning to happen, then please look very closely for any chance of pneumothorax or try to adjust the parameters so that it doesn't really cause trouble. Okay. And in terms of another important loop where we see is the flow volume loop, where we have heard that before, where the expiratory limb goes onto the y-axis and doesn't reach the baseline like it should. Secretions, if they are there, they are going to show up in all the forms of loops as much as possible, the pressure and the flow scalars like that. But if you look at so if you have a baby who is very uncomfortable on ventilator, fighting the ventilator, even on minimal parameters, the possibilities are, one, the parameters are not adequate. Two, there is a lot of secretions that are troubling the baby in terms of ET secretions. When we see something like this, the inspiratory limb is smooth because it is an active process, the expiratory limb is showing a sawtooth pattern. The first step that we do is we do suctioning. The second step that we do is the baby ready for extubation or not, evaluation of extubation readiness. The third step we do is, if the baby is not ready for extubation, even after the secretions are clear, the baby is still uncomfortable, then probably mild sedation will help the baby tolerate ventilation better. I'm going to talk about two practical case scenarios where pulmonary graphics probably saved the baby from either excess investigation or from excess from a wrong step in treatment. Okay, we had a baby about 5 years ago who has had mass outbound baby brought with PPHN, intubated, ventilated, requiring high parameters. On ventilation, 6 hours into ventilation, baby had a sudden collapse on ventilator. So this for the benefit of the residents, whenever a baby has sudden collapse on ventilator, we think of something called DOPE, D-O-P-E. D is for tube displacement, O is for tube obstruction, P is for pneumothorax, and E is for equipment failure. So the first thing that we do is we disconnect the baby from ventilator, put a test lung to the ventilator, and start bagging the baby on with either with neopuff or with ambu bag. So if the ventilator is working well on the test lung, that means equipment failure is ruled out. And if while you are bagging the baby, you notice that there is good chest raise that rules out both tube displacement and obstruction. That leaves the possibility of pneumothorax being a good possibility. So when we examined this baby we had disconnected from ventilator. The ventilator is working fine. When we had started bagging the baby, there is air entry, but on one side of the lung, on the right side of the lung, we did not hear any air entry that going on well. Okay, the graphics also showed the typical flow volume loop showing that it is not going reaching the baseline. So there's a lot of air trapping that is happening in the lung, so which we had gotten an urgent X-ray. X-ray also confirmed that there is a pneumothorax. By which point we already put a needle drainage of the second intercostal space and found there is an air bubbling, and then we also got ready for ICD insertion. ICD was inserted and the showed good bubbling for one full day, and then after that the bubbling slowly stopped, and then there was serum that we noticed in the ICD tube, and then the baby seemed to have gotten better. The ventilator parameters have slightly decreased. However, one wonderful resident had noticed that there is persistence of the pulmonary graphic showing air trapping on air trapping. So he had taken a decision of ordering a repeat chest X-ray before removing the ICD. He wanted to be very sure that probably the pneumothorax completely resolved, because the graphics are still showing air trapping. The repeat X-ray showed something like this. So there is an ICD in place, but there is a lot of air trapping still going on with this baby's lung. So this tells us that even though the ICD was there, it was blocked for some reason, and the air trapping was continuing to happen. Even though the ventilator parameters got better, the pneumothorax didn't resolve. So had we just removed the baby's ICD without doing the X-ray, we would have missed this pneumothorax. What we had done was we had put another ICD for this baby, and the baby's ventilator parameters further improved very rapidly, and the baby got out of ventilation very quickly. Second scenario, there was a baby, outbound baby, referred to us because of excessive distress at birth. The parents gave a clear history saying that the baby had very noisy breathing. Took to a doctor. Doctor said baby is having difficulty in breathing, and a baby was not tolerating non-invasive ventilation. Was put on baby was intubated and then referred to higher center. So when the baby was on the tube, we have connected the baby onto the ventilator, and then the ventilator graphics showed something like this. Otherwise, the baby was an angel on very minimal parameters. The expiratory loop was not very good. When we saw the expiratory limb showing nice caved out, collapsing form is what we call it, then we ordered for a bronchoscopy for this baby. When we ordered the bronchoscopy for this baby, there was an extensive tracheomalacia in this baby, which resulted in this form of noisy breathing. So technically, all the RD, the respiratory distress the baby had was just tracheobronchomalacia. That's all. All we had to do was tolerate the noisy breathing, nurse the baby prone when possible, and then we could extubate the baby quickly. And then we put the baby on follow-up. By around 9 months, the baby's tracheomalacia began to improve with time. And we cautioned the family about any form of minor respiratory illnesses such as cold, cough to stay away from the baby. And we gave, even though this is not a routine practice, we gave something called vaccine cocooning, or we gave flu shots for every family member in the family. Thereby, they wouldn't harbor any influenza viruses, thereby not causing trouble to this kind of baby. So a simple pulmonary graphic helped us identify a diagnosis. A simple pulmonary graphic helped us even manage a baby better in the previous scenario. Summing up, graphics are useful in understanding the evolving pathology of neonatal ventilation. They help us pick up acute changes and can be life-saving. And they can also help us make diagnosis like we discussed just now. And most importantly, they are bedside. They notice every breath, which we cannot do in any other form of monitoring. Your ABGs, your X-rays are all point snapshots, but then this pulmonary graphics is a very real-time monitoring of a baby on ventilation. If I were to put a baby on ventilator, the first loop that I look at is the PV loop, the pressure volume, the pressure volume loop. I would want to see whether my PEEP is optimal or not, the compliance of the lung, and I want to make sure I'm not using too much PIP. The second thing I do is look at all the scalars, particularly the flow scalar, to look for any secretions, whether my eye time is too much or too little, whether there is any air leak or air trapping that, that is there at the same. The third thing I look at is the flow volume loop, again to look for any air leak or air trapping or secretions that are there in the lung. And this continuously looking at the pressure, flow, volume scalars and loops is an ongoing process when we are ventilating a baby. Thank you. I'll be happy to take any number of questions if there are any. I would like to thank the organizers for giving me this lovely opportunity to re-look into my area. I mean, I love this topic, and then also re-look into it one more time and be helpful for some of the residents.
Thank you, Dr. Kalyan. It was an excellent presentation. Anybody would like to ask any questions?
Yes, Preeti. Uh,
Sir.
just a second, just a second. Uh, I mean, it was an excellent lecture, definitely. There is no doubt about it. But what I want to ask that your name sounds very much like Bengali. I mean, what is there? The Kalyan Chakrabarty is usually a Bengali name.
Thank you, sir. Thank you. And actually, I get asked this question multiple times. আমি বাংলা বুঝতে পারবে বলতে পারবে না. That's all of Bengali I could manage. I'm from Andhra Pradesh, sir, and Chakravarti is actually a name that is quite popular in small part of Andhra Pradesh as well, sir.
Okay, okay, okay. Thank you.